So hello and welcome everyone. Good morning, good evening, depending on from which part of the world you are watching us right now. I'm Nicholas from whatclinic.com, one of the most popular online directories for finding treatments all over the world. And I'm honored today to meet Dr. Anna Voiskuilen from Reproclinic. Reproclinic is a fertility clinic located in the center of Barcelona in Spain, and it's a brand new IVF clinic opened in 2018 and treats international patients only. So I'm really honored to meet Dr. Anna. Welcome, and
thank you very
for
much.
having me here.
Good afternoon or good morning or whatever for everybody.
And this webinar is going to be really interesting because we will get answers to some popular questions all people may consider having fertility treatments may have. So, Dr. Anna, before we start, could you please tell us some things about yourself so we get to know you better?
Yes, of course. So I'm gynecologist, specialized in reproductive medicine, of course. And when I finished my trainee program of general gynecologist, I went to New York for 3 months to learn more about fertility. And then I came back, and since then I've been working in fertility. And I think it's an amazing part of the gynecology. And I'm personally interested in that because I know someone very close to me that needed treatment. So I was always, I had always this in my mind when I started to study medicine, and that's why I choose to do that part of the medicine.
It's very interesting. It's a part of the medicine that helps a lot of people and makes many dreams come true.
Yeah.
So before we proceed to the first question I have for you today, I want to inform everyone who's attending the webinar right now. If you have any questions, feel free to write it in the chat box here on Zoom, and I will ask the doctor live a little bit later. So I'm really curious, how common is female and male infertility?
Yes, so what we know is that it is estimated that 10 to 15% of the couples that are looking for a baby will have some problem, some infertility problem.
Mm-hmm.
And we also know that for every month that we try to get pregnant, we have like between a 20 and a 30% of probabilities of getting pregnant, so having normal intercourse at home, if everything is correct. And if we compare that with other species of animals, this is very low, actually. Mm-hmm. So this is one of the things that is also important to take into consideration. And also I want to tell you, we have different factors that can impact the fertility. On one hand, we have what's called the male factor, that could be like more or less a 30%. On the other hand, the female factor, 30% more or less also. Mixed factors, so both factors together, also more or less 30%, and then a 10% that would be unknown fertility. Mm-hmm. Okay. And the other important thing is that it's very important to know that fertility, and more for female, decreases with age. Mm-hmm. And we know that because we know that the ovarian reserve decreases in terms of numbers, but also in terms of quality. And we can test the numbers, so we can have different tests to see how the ovarian reserve is, but there's no test to see how the quality of the eggs is. And this goes related with age. And that's why we specialized people in reproductive medicine, we always talk about age. I'm sorry for that, because mm-hmm. It's because we have to work with those statistics, because there's no test to see how the quality of the eggs is. And saying that, why do I think that this part is important to know? Because actually nowadays, we try to get pregnant much later than before. Mm-hmm. Because if you compare with your parents or with your grandfathers, probably they will have looked for a baby much earlier. So this means that right. Probably mm-hmm. It will have been much easier for them. And that's one of the main reasons that explain that fertility problems are increasing. That's because of the age factor.
Mm-hmm. Understand. So what is the moment, the perfect moment that someone should consider having a consultation with a fertility specialist? I guess know when they grow a lot older. So how can I know when it's the right moment for me to contact you?
So it depends on the age. We classify it by age because we are more in a hurry after 35 years. So until 35 years, we can wait for 1 year. So we know that 90% more or less of the couples after 1 year will conceive. So that's the reason why we tell them to wait 1 year. And if it doesn't happen, consult a specialist. And on the other hand, if it's above that age, we will recommend it to go to a specialist 6 months after trying to get pregnant. But of course, saying that, it's also important to take into consideration if you have like an endometriosis, or you have had problems with the tubes, you have fibroids, anything that could impact the fertility, then you should ask before because it could have an impact on the result.
So to sum up, if I understood correctly, if a couple is trying to conceive a baby with a normal intercourse and they cannot conceive during the first 6 months, then it's the best moment for them to contact a specialist or gynecologist.
Yes, it
to
would
see
be
what is
like
happening.
between 6 months and 1 year. So under 35, you can wait a little bit more because actually we have time, let's say, to that, and we know that most of the couples conceive in that year. But after 35, it's better to not wait too much and then go and do the test and everything.
I understand. Thank you for clarifying this. And so let's say that I decide to contact a fertility specialist. What are the steps I'm going to follow?
So the first thing is that the patients do the consultation, and with the first visit, what we do is we ask all the medical history, if they have done some other fertility treatments before, if they're taking some medication, anything that could impact the outcome. So it's a visit to know about both people, or about if it's just a patient, about the patient. And at that point, after that, after the very first visit, we will tell the patients which tests are required. Then they will have time to do all these tests. They can do it in their countries. And then the last part will be doing a second visit, go through all the results, and then see which is the best option for the treatment. And from that point, then we can start with the treatment.
The treatment. About the first phase, the first step, the consultation step, given the fact that you are working mostly with international patients, can this be done online via Skype or any other video conference?
Yes, so we do a lot of visits online. Of course, if they want to come, they're invited to come here as well. Now it's a little bit difficult with all the COVID situation, but still they can come. But normally we do our first visit online. They do all the tests in their original countries. If there's some tests that it's difficult to do, they can come here, do a specific test. Of course, we can do all the tests required as well. They can come and freeze the semen sample, for example, and all these things. But normally our patients do it abroad. And then the second visit can be also online. We go through everything, we talk about everything, and we start to organize the treatment, which can be the first part of stimulation or controlling and following up. The stimulation can be done in their original countries, and then of course they have to come here for the egg retrieval or the embryo transfer or the insemination.
Very interesting. And this is something very convenient, especially during this time of the pandemic, which makes it difficult for people to travel abroad. So they can contact you via an online conference meeting and send you their examinations, their papers, so you can evaluate them and tell them if they need to do something more.
Exactly.
So many people have asked about several different approaches in fertility treatments. How can they know which one is suitable for them?
This depends on the test, because it's very important to see with every couple or every patient, we have to analyze his own situation. So we need to know how, in one hand, what's the age. On the other hand, if they have some problems, medical problems or gynecological problems, we have to test the ovarian reserve to make sure that everything is correct. Of course, we have to test the seminogram. We have to see how this part is. And regarding to that, we can think about doing one process or another. For example, young people, everything normal, could be more an insemination. Someone that has low ovarian reserve, older, then more for IVF. So it depends on every patient and every situation. The other thing is that also regarding to what we see and the options that the patients can choose, we will also ask other additional tests like hysterosalpingography, which is looking at the tubes to make sure that they are open. This is important, for example, in insemination, okay, but not for IVF. So regarding to the results of all these tests, we will decide which of the treatments is the best one.
So it's not something that the couple can choose. It's about what is suitable for them according to their results for the examination.
Yes, of course. Sometimes I can say, look, I think that one is better, but they prefer to start with IVF, with the IUI, or directly I say, look, you can think about an insemination, but they prefer to go directly to IVF. I mean, it's something that is a relation and that we decide together.
That's clear. One of the most popular procedures people choose in our website is the IVF. And this is the procedure I mostly know about. So could you tell us more about what IVF is and what are the benefits or the drawbacks of this procedure?
So what do we do? I will start with what we have in a natural cycle. So when we have a natural cycle, in our ovaries, we have different follicles that can grow in response to the hormones that we have. For example, we have 12 follicles in total, and these follicles could grow in response to the hormones, but we just have hormones to make one of these follicles grow. Okay, so in a normal cycle, we ovulate just one egg, and we normally get pregnant of one baby at a time. Okay, and the other follicles are like lost and they stay there. What we do with an IVF is give more hormones. So make the patient inject some hormones to increase this dosage of hormones and to let all the possible follicles grow. Okay, so at this point, we don't have just one egg, but we have more eggs. The number, it depends on every patient because it depends on the ovarian reserve. And of course, it depends on how they're going to respond. But what they have in the beginning of the cycle, so the basal ovarian reserve, we cannot change it. What we can change is that you don't just ovulate one egg, but more eggs. So with IVF, we do that. The stimulation is injections that the patients put every day, same time during 9 or 10 days. And during the stimulation, they will do some controls. Normally it's 3 controls, which means an ultrasound and a blood test to see how the follicles are growing and how the hormones are growing. And then we can decide what to do, if we need more medication or not. And after this stimulation process of 9 or 10 days, if the patient is ready, we will program the egg retrieval, which is in an operation room under sedation. And what we do is we take these eggs out of the ovaries. Okay, so we don't want the patient to ovulate because we want to get those eggs and we want to bring these eggs to the lab to fertilize them in the lab. So that's why it's called in vitro fertilization, because the eggs are fertilized in vitro in the lab. Okay, and after that, of course, if we have a certain number of eggs, then we put them with a sperm sample and we wait for 5 days until we have 5 or 6 days until we have the blastocyst stage, which is the stage of the embryos in which we have the maximum implantation rate. And at that point, we can transfer the embryo. And that is a little bit the general idea of IVF. So working not with one follicle, but working with a lot and taking the egg and fertilize the egg in the lab and put back an embryo.
Why this procedure is so popular? Are there any specific benefits? Is it because it's more easy to do, or the results are more probable to be positive?
Yes. So the thing is that if you compare that with an insemination, for example, the thing is that with an insemination, you can work with 1 or 2 follicles, not more than that, because the last part of fertilizing the egg, you don't control it. In insemination, we control the process, the follicular growth, and in the correct moment, we trigger the ovulation and we program the insemination, which is putting this sample inside the uterine cavity, and then nature's work. So we cannot control how many eggs are going to be fertilized. So that's why we can work with 1 or 2 eggs, not more than that, because we don't want multiple pregnancies. So the difference with IVF in that sense is with IVF, we work with more follicles. So we will have more eggs and more probabilities of finding the good embryo to get pregnant. And also the process is much more controlled because you control the fertilization, you see how the embryos develop, and you put a good quality embryo in the uterine cavity. So it's not just putting the spermatozoids and waiting, it's much more detailed. But this is the positive part. The negative part is that, of course, it's it's more expensive, okay, than doing an insemination, and it's not as natural because you need to put more hormones and you need to go to the OR and have a sedation. So that will be the negative part of it, I would say.
Great details and great information. Thank you for the clarification. So about the IVF process again, how long it takes until we get to see some positive results or some results in general?
So the IVF process, normally it starts with menstruation, and more or less after 2 weeks, the egg retrieval will take place, and 5 days later will be the embryo transfer. So more or less you have to count like 3 weeks.
3 weeks.
But it depends, because sometimes we prepare patients before the menstruation with some kind of medication, 1 week before or even more sometimes. So this could make it a little bit longer. And on the other hand, it could also happen that we need to do this process of the IVF in 2 parts. So first, take the eggs, and after do the embryo transfer. So do it in 2 parts. Why? For 2 different reasons. It could be one of the main important reasons. One would be if you want to do a genetic test on the embryos, and then we need to create the embryos and we need to test them and wait for the result. And once we have the result, then we program the embryo transfer in another cycle. Okay. And the other case would be if someone has a very high response, to avoid the risk of having an ovarian hyperstimulation syndrome, what we do is we don't transfer in fresh, but we freeze the embryos, and we do the embryo transfer also in another cycle. With next menstruation, they start preparing themselves, and then we do the embryo transfer.
That's clear. So one of our viewers asked about the single embryo transfer. What are the pros and cons of a single embryo transfer?
So I have to say that I prefer always a single embryo transfer. Okay, of course, it depends on the age and the quality of the embryos, everything. But generally, the best thing, I think, would be putting 1 embryo at a time. Why? Because it's important to avoid twin pregnancy if it's possible. Because twin pregnancy, even if it's super beautiful and it can go well, of course, it's a high-risk pregnancy. Because you have 2 babies in your belly. So there's a higher risk of preterm delivery, higher risk of having other complications, hypertension or diabetes. So it's always, and more problems during giving birth as well. So actually, if it's possible, I would say try to avoid it. But this is in an ideal world, because every time that you do an embryo transfer, you have to pay, you have to prepare yourself emotionally. I mean, it's a time that you waste. So some people choose to, depending on their age and the probability of having good quality embryos, and depending on the quality of the embryos, sometimes they decide to put 2 in the same transfer to at least increase a little bit the possibility of getting pregnant. But still, I mean, the best thing would be in an ideal world, be doing a single embryo transfer, and more with people under the age of 35, and of course with egg donation.
So it's a less risky procedure, let's say, and more controlled.
Yeah, so I think the procedure is the same thing, doing it, of course. But yes, after, if you get pregnant of a twin, I mean, if you have a twin pregnancy, the risks are much higher during the pregnancy.
Understand. So another fertility procedure is the ICSI or ICSI. Could you tell us a little bit more about this procedure?
So normally what we do in a normal IVF is after the egg retrieval, we take these eggs, we bring them to the lab, and we put them together with a sperm sample. And let's say we let the nature work. So we let them become fertilized with the best spermatozoid that will arrive. Okay, let's say it like that. In some specific cases, we cannot do that, and we need to do the ICSI, which is injecting the spermatozoid inside the egg. Okay, and this is normally indicated when we have an important male factor, so problems with the semen sample, with the seminogram. And then, of course, like movement, mobility, or forms, or also decreased number of motile spermatozoids. So with a male factor is when we normally do an ICSI procedure. Other cases are when we want to do a genetic testing of the embryo, or, for example, when we are using frozen eggs, because we know that after freezing the eggs, when we throw them, the eggs are a little bit, the outside part, the external part is hard. So we need to insert the spermatozoid inside the egg. And the other case, I had another case in which I would do an ICSI. I don't remember now if I have it. But I will tell you. I think it was, so male factor, vitrification, PGT. Oh, yes. And if we have had a problem with fertilization previously. So if a couple, for example, has done an IVF previously and has had 0% of fertilization, in that sense, in that kind of cases, we go directly for ICSI. When we don't have this kind of information about this, so we don't know if the partner has ever become pregnant together and things like that, sometimes we do what's called mixed fertilization. So half of the eggs with IVF and half of the eggs with ICSI, to try to avoid surprises in that sense.
So can we say that if we tried every other procedure, ICSI would be the last option to get pregnant?
It would be, I mean, if it's possible, it's better to do it with a natural IVF.
Try it. Okay.
And if it's not possible, or we know that there are some specific cases that we need to do ICSI, then go for the ICSI. Yes.
Understand. So another procedure is the AID, artificial insemination. When this procedure is recommended to be followed?
So what I told you a little bit about artificial insemination was that it depends, of course, on the test that we see. So normally, this would be recommended in a couple that is has maximum 37 years old, I would say, couple, or a patient that wants to become pregnant alone, also, same thing. When we don't have a male factor that can make it difficult to have a natural fertilization, and we need to do ICSI or something. I would say also, well, when, of course, we know that the tubes are open, but it's something that you can look at with a hysterosalpingography to make sure that the tubes are open, that there's the permeability of the tubes. But it's still something that is optional. So I always tell the patient, in this sense, the hysterosalpingography is optional. It depends on every case. For example, if I have a couple of two girls, I will tell them that, of course, it's always better to make sure that your tubes are open, but if they don't want to do it, I mean, I don't see the reason why they could not do the procedure without looking at the tubes. Of course, it depends on if they have had surgeries, if they have had infection or any problem that could make me think that there could be a problem with the tubes. So that would be one of the things. And the same thing, well, with people that want to get pregnant and to be moms alone, same thing. So actually, we're not looking at the problem of infertility, because actually the problem is that we don't have that sperm there, right? So in these two cases, I would say that it's optional, but of course it depends on every patient.
And what about the PGT procedure? When is this procedure recommended?
Yes, that's testing the genetics of the embryo. So there are different kinds of PGTs. We have the first one, and the most common one is the aneuploidies, which is looking at the chromosomal abnormalities of the embryos. Actually, it's something that we normally recommend after the age of 38 years, more or less, because we know that at that point the quality of the eggs has decreased. And what we know that happens when this quality of the eggs decreases is that it's more difficult to get pregnant. There are more miscarriages and more chromosomal abnormal embryos. So what we can do is, before doing the embryo transfer, looking at the genetics, at the chromosomes of the embryo, and make sure that the embryo is normal before transferring the embryo into the cavity. So actually it's something, we have the normal with the aneuploidies, which would be the most common one, which would be that one. We have other ones that are more specific to look at specific problems of the karyotypes of the parents. So when we have a karyotype, which means that the normal number of chromosomes and everything of the partner, of the two people of the partner, of the couple, when we have a problem with their karyotypes, then there's also a specific genetic test of the embryos to make sure that we can put a correct embryo in the uterine cavity. And there's the third one, which is more specific for monogenic diseases. It means when some patients are carriers of some genetic disease, because they have a family history and they know it and everything, and then they test this before putting the embryo back.
And how old the embryo needs to be before you can do a PGT in order to have more reliable results?
So actually, it needs to be a blastocyst. So day 5, day 6. What we do is, in a blastocyst, what we have is like an external part of cells and an inner mass cells that will, the inner mass will form the embryo and the external part will form the placenta. So we take the biopsy from that part, from the external part, and then what we do is we freeze the embryos, because we need to wait for the results, which take some weeks, because it's genetic, and everything that's genetics takes more time. And what we do is we freeze those embryos, we analyze it, and then when we know that which one is the correct embryo, then we put the embryo back.
It's amazing the progress science has done. I'm really amazed by all these procedures. It's great. Yeah. So I've seen the statistics in our website, and I see the demand for fertility preservation increasing. Why do you think this is happening?
So I think because first thing is because of the age, because we know that we want to have children later. The age of conceiving and of trying to get pregnant is later than before, as I already told you. This is one of the reasons, and because we know that age affects fertility. And the other very important thing is because we have the information. So people have every time more and more information about that. So they know that they have this option of fertility preservation, and then they want to proceed with like this kind of treatments. Of course, I always tell it's like a little bit an insurance. You have these eggs frozen. The best thing is that you never need them, that you never need to use those eggs. But in case of needing them, you have them. And of course, if you need them, you can thaw them and fertilize them and then try to get pregnant. It's never 100%, and it's something that everybody needs to know. And of course, the more eggs that you have, the more probabilities if you need to use them in the future. And it also goes correlated with age. The less age that you have, the better. I would say fantastic under 35 or maximum 35, but also from 35, 37. It's also interesting because the quality is also good, and the probabilities of needing them is higher than with people that are going to preserve the eggs before 30 years, for example.
Understand. So we have a question from Maria about egg donation. She asks, where are the donors coming from and what are the selection criteria?
So we have our own donors that are continuously renewing. Of course, we have continuously renewing donors. And what we do is everything. I mean, we do all the tests required by law. So karyotypes, infectious diseases, personal history, familiar history, gynecological tests, everything. And when we see that everything is correct, they can become donors. And we do all the process here in our clinic. So we do the test, we select them, we choose the best donor for each patient, and then we do the part of stimulating the donor, taking the eggs and fertilize the eggs with the sperm sample of the partner of the recipient. What was the other part of the question? I don't remember it.
And from where they're the selection criteria of the eggs.
Selection criteria, yeah. So the selection criteria, first thing is that it's totally anonymous, so you cannot know who the donor is, and the donor is not going to know who you are. And the selection criteria is regarding to the physical characteristics. So the donor needs to look like the recipient as much as possible. So it means that we're going to look at the color of the skin, color of the eyes, color of the hair, texture of the hair, general body mass index, and also we work with pictures. So we have the phenomatch, but also we work with pictures. We prefer to see it with all the team of the donation team, and make the best match physically speaking.
While preserving all the time the anonymity of the donor, right?
Exactly. Absolutely, yeah. So they cannot see any picture or nothing like that. That's also.
Thank you very much for your answer. So let's talk about another subject right now, which I recently discovered, and it interests me a lot. It's about shared motherhood in Spain. Could you tell us a little bit more about what is the shared motherhood?
So it is when we have a couple of two females. It's when one of the females of the couple is going to create the egg. So it's going to do the first part of the stimulation, and we're going to take those eggs. What we do is we create embryos with a sperm donation, the donor, and then these embryos that we create, we put them in the partner. So in the recipient. So these two girls, which are two girls, one of them is going to put the eggs, and the other one is going to receive the embryo, is going to wear the pregnancy. Wow. So that's the way that they can participate both. I think it's super nice. And actually, it's the only condition in which donating eggs can be done without being anonymous. Okay,
this is amazing.
Normally it has to be anonymous because it's with egg donation, it's absolutely anonymous. But with shared motherhood, it's a process in which we can do it in this way. And actually, what we do is we synchronize them. What we do is we start a little bit before the recipient, the one that's going to receive the embryo. We start the menstrual preparation, and then she waits for the embryos. And at the same time, a little bit later, the one that's going to be the donor of the eggs, we stimulate her. It's like 9 or 10 days. 2 days after, we take the eggs, we fertilize them, and 5 days later, we put the embryos in the recipient part. of the couple. So it's something in which they have to be synchronized normally. Of course, we can also do it without synchronizing them and first do one part and then the other part. But normally, and more with patients that are abroad, they prefer to be synchronized to do all the process together and come here together. And it's very nice. I think it's important because they can share. Actually, the word is like that, shared motherhood. They can share this, and they can both participate in the process. An important thing is that they need or to be married or to have some legal specifications to demonstrate that they are a partner, that they are a couple. Okay, that's important because of what I just told you is the only case in which you can donate the eggs to another person without being anonymous.
So does it matter from which country they got this legal authentication of their marriage, that they're legally married? Does it matter?
Of which, no, I mean, we need to know that they're legally married, or we have like other kind of things, like, for example, in French, I think it's called paxé, which in Spanish is pareja de hecho. I don't know exactly the name in English. So actually, we need to have a confirmation that they're a legal, formal partner, couple.
Okay, so any legal confirmation from their country?
Yes. Actually, in this legal part, we tell you, regarding to every country, we tell you which is the thing that we need in that sense.
That's very interesting. And I'm really surprised and excited about the shared experience you mentioned before. Like one partner offers the eggs and the other partner carries the baby. It's super beautiful.
Yes, it's super beautiful. And I like to help them a lot.
Beautiful. So, and for the shared motherhood, which procedure is followed from the previously mentioned procedures?
So how does it go, more or less, the procedure? So, as I said, we need to synchronize them. So normally we put one of them or both. We give them birth control pills to synchronize the cycle and start whenever we want. The part of the recipient is once the recipient is going to have the menstruation, she starts the preparation with estrogen tablets or patches during 10 or 12 days. Then we do an ultrasound and a blood test that they can do in their countries to confirm that everything is correct to receive the embryos. And at that point, they wait for the embryos, okay? Because we do what's called a medicated cycle. So the ovaries are not working, and that's why we can have this flexibility of waiting for the embryos. And on the other hand, the one that's going to give the eggs, she will start some days later. She will start with the stimulation, more or less what I told you, like for IVF, right? Injections every day, 9-10 days, 2 days after the egg retrieval, and during those stimulation, 3 controls normally to see that everything is going correctly and to see when we can program the egg retrieval. And after the egg retrieval, 5 days later or 6, we do the embryo transfer, and that's it. So normally it's like, I would say like 3 weeks, 1 month, something like that. That the first part of the procedure can be done in their countries.
That's very interesting. So one more question I received about the phenotype matching and donor eggs, and if the baby will look like the mother. So I think this is something that you already replied before.
Yes, what I told you, right? We need to do it by law, and we need.
That's what I wanted to ask you, if it's needed by the law. So if a mother asks you not to do it, you have to do it. The matching. Okay.
Exactly. Exactly. The donor needs to look like the mother that's going to receive the eggs, as much as possible, knowing that no one is identical to other person, but with general characteristics and also with the shape of the face, everything. So we try to work also with the pictures to make the best match, best possible match.
So is there something like a list that you need to follow?
Yeah, so what we do is when when we talk about all this in the first visit, after the first visit, we sent a formulary that the couple can fill in with their physical characteristics, everything. And also we asked them to send some pictures of both to make the best selection.
Interesting. Thank you for your answer, Doctor. Maria asks one more question. Is there anything you can recommend, Doctor, to prepare the uterus or the endometrium before the fertility treatment begins, like vitamins, hormones, or something like this?
So, in terms of general information, of course, I always recommend before having an embryo transfer, starting with multivitamins with folic acid. That's important because we know that folic acid is something that's very important during the pregnancy. It's very important for the nervous system of the baby, for the neural tube formation. So it's something that you should start a little bit before to have a correct level of folic acid in your body. Okay, because all this process of the neural tube and everything takes place in the beginning of the pregnancy. This is the first part. And then regarding to the uterus and everything, let's say there's a case now thinking, there's a case in which I would give some kind of preparation before. So for people that are on menopause, I would recommend to do 1 or 2 cycles with hormones to make this endometrium line grow and then menstruate and then again grow, and then do the real preparation to try to prepare this endometrium and this uterus again for the hormones and for receiving an embryo.
That's clear. So talking about what may influence the fertility, what can in general influence the quality of reproductive health, both for female and males?
What can influence? So it's important to know some different things, general things that I would say. For sure, in general, what would I say? Have a healthy lifestyle. What does it mean? Do regular exercise, moderate exercise. Try to avoid toxics like alcohol, smoking. Try to avoid abuse of caffeine, so not too much caffeine. But this is a little bit pretty much the same as when you get pregnant. I would say also varied diet with fresh vegetables, fresh foods. Try to not eat a lot of processed foods. So more fresh and everything than at home, it's better. And try to avoid saturated fats as well. So this kind of general things are the ones that I would in general recommend. It's true that saying all that, it's unclear if it's going to have a big impact on the fertility. So this is what we normally recommend. Also taking omegas, what I just told you about folic acid for the levels of folic acid, all these things which are more in vegetables, in nuts. Also in terms of if you're vegan, you should look the levels of B12 because it could be lower than the good normal range. But all this goes a little bit with the thing of preparing yourself and controlling the diet and everything. It's true that with vegan people, a lot of foods have supplements of vitamin B12, so it's normally not a problem. And also other things that could boost, which this is well defined, which is the BMI. So actually, the thing is that we know that if you have a high BMI of a very low BMI, it could decrease the possibilities of getting pregnant. So what we normally recommend is try to normalize this, okay? Because it's something that could have an impact. For example, if you have higher BMI than 30, it could have an impact on the miscarriage rate, for example, or problems during pregnancy, during birth giving, and all this. sometimes we tell patients to try to decrease it. Of course, it's not as easy as saying it. And sometimes they require a treatment with nutritionist or with some coaches or things like that.
So a healthy and balanced lifestyle increases the chances of conception in the future.
It's not something very, very big, but it's what we normally recommend, of course.
Maria asks, I think it's about the previous question.
Yes, about 3 seconds I've seen,
yes.
right? Yeah, that is hormonal replacement treatment. So in this, it would be something like that. Yeah, but it depends on every different specific protocol that we give, but it would be something like that.
When someone starts fertility treatment, is there something that needs to be changed or be taken care of in their lifestyle, in their health diet? Can they exercise?
So, well, in general, just resuming what I just told, I think exercise a lot, so avoid sedentary life. So do a little bit of exercise, moderate exercise, not extenuating exercise and a lot of hours, and not just moderate.
Just keeping your body active.
Exactly. Yeah, more or less that's the thing. And eat a varied diet. I mean, eat a lot of things, different things, fresh things. If it's possible, ecological things without any pesticides and things like that, which is not as easy as it seems because it's also expensive. But this will be a little bit the general things, and again, try to avoid smoking, alcohol, this kind of things.
Again, healthy and balanced lifestyle, not only diet, but lifestyle. So in the Reproclinic, you're working mostly with international patients. We talked about the beginning and the evaluation phase, the consultation phase, that this can be done online and send you the any exams and evaluate them by distance. After that, how many times they maybe they have to travel to Spain or back to their countries? What is the procedure after the consultation phase?
So actually, if it's, for example, actually, whatever kind of treatment it is, they can do the first part of stimulating or preparing the endometrium or doing the controls of an insemination. Whatever it is, they can do that first part in their own countries. And then once we see that they're prepared for the egg retrieval, for the insemination, for the embryo transfer, then we can organize it and they need to come here to do the procedure. Of course, it depends on every procedure. They will need to be here 2 days later or 1 week later or something like that. So normally in these cases, you can do like just the procedure here. We also have patients that prefer to do all the treatment here with us. It's not a problem at all. Okay, so that would be they come here and they stay for 3 weeks in the case of an IVF, for example. And in some other cases, for example, with egg donation, we have different kind of protocols to work with. Normally what we do is the partner, the male partner comes here to our clinic to leave a sperm sample and do some additional tests. We freeze the sperm sample, he goes back, so he can just come here for 1 day and go back. And then in a second time, they come for the embryo transfer, 1.5 days again. So we always recommend to be here the day before the embryo transfer and then leave the day after the embryo transfer in cases of egg donation. Okay. And so it depends a little bit, but actually the thing is for the procedure, you should be here, or also could be the last control, be here. But the rest of the treatment can be started in their own countries.
So you mentioned about IVF that they may need to stay like 3 weeks in Spain and then go back to their countries. Do they need to come back to Spain at one point for some additional examinations, or that's it, this 3 weeks in Spain and then?
But I mean, 3 weeks is like when they start the stimulation until they have the embryo transfer. That's like the main important part. If they want to do some kind of diagnostic test before, that all the diagnostic part should be done before.
Okay.
So they could come just for one day and do the pap test, for example, blood test, everything that is required. They can come together, leave the sperm sample, do everything, just one day and go back. And then for the procedure, if it's an IVF, it can be 3 weeks. If it's an insemination, it should be like 2 weeks. It depends on every procedure. But normally what we see is that patients just come for the egg retrieval or for the insemination or for the embryo transfer, because it's more easy now with the COVID and everything. But I have to say that it's still, now with people working online, it has made it easier to come here to do the whole treatment. Okay, so I have some people that have come to do all the treatment here. So from the beginning of the stimulation till the end, and because of the online possibility.
So they combine the treatment and the vacation as well. And it's a beautiful place to do both in Barcelona.
Yeah, it's a possibility.
One more question, and this is the last question I have for tonight from one of my colleagues, is about stress and how stress may impact the fertility outcome.
So it's, I mean, there's not enough evidence to say that stress can have an impact on the outcomes. But let's say that the thing that we know is that people that need fertility treatment will have a lot of stress. Because no one that thinks about creating a family thinks that they will need to do these kind of procedures. So it's very stressful in this sense that they need some time to accept and also the situation. I would say that in this sense, what is recommended is to share these emotions with family or with a friend, with a couple, of course. And sometimes if you prefer it, also with a psychologist that can help them manage a little bit these emotions and the stress and let them out, like to say it like this. And the things that could help in that sense would be like doing, for example, yoga, meditation, or whatever activity that can make you disconnect a little bit of all this stress and all this process.
And one more question I received just right now is about single motherhood, single mothers. Is this has to do with shared motherhood, or this is another subject?
Another subject. So it means that a woman wants to get pregnant and have a baby herself without a male partner and without a female partner, so alone. So we also help these patients to have their babies, because of course it can happen that in your life you don't find the correct
you want to be alone. Or you want to be alone, which is something
exactly
respectful.
That's also a thing. I mean, like people that want to be alone, people that doesn't find the correct person, but still they have super clear that they want to become moms. And in that sense, it's easy in women because they can do it alone in that sense. And we help them, of course, we help them with regarding to the age, the test and everything, or with insemination or with IVF or whatever it is. Sometimes when they have more age, then it could be also embryo adoption, things like that.
So in this case, you're using the sperm donators and you do the phenotype matching with a mother.
Exactly, same thing. So we need to know the characteristics and to look for the best donor in terms of physical characteristics. And then, of course, the same thing. The donors are tested for the same things: karyotype, psychological test, personal history, family history, all these things to make sure that everything is correct and that they can become donors. And it's, again, absolutely anonymous.
That's great. I admit that I learned a lot of things today. And thank you for being so clear and so detailed in answering our questions, mine and our audience's questions. If someone wants to contact you, how they can find you, how they can contact Reproclinic?
So they can contact us by the web, Reproclinic. and we will help them, and we will give them a first visit, and if they need anything, then we can have a talk and know each other.
That's great. That's great. So thank you very much, Dr. Anna, for your time today and for this amazing conversation we had.
Thank
As
you
I
very
met,
much.
I learned a lot, and it's very interesting to learn how the science has progressed so much and all the different options in order to make future parents' dreams come true.
Yes, it's true. It's true. It's an amazing topic. I think the
Yeah.
reproductive medicine is amazing.
Yeah. Thank you very much, and I hope to see you soon.
Yeah, thank you very much for inviting me. Bye bye, everybody. Bye.
It was nice. Good one.